Good evening, everyone. I think Dr. Praveen will start off with the class. Today's class is on intestinal obstruction. He'll only be discussing about the etiology and manage investigations. I think next management class will be taken by Dr. Lakshman, I suppose. Praveen,
Yes, sir. Um,
yeah, you
good,
can start off.
sir. Good evening to everyone. Today's seminar will be on the intestinal obstruction, its types, causes, pathophysiology, and its clinical presentation. Intestinal obstruction can be defined as significant mechanical or functional obstruction of intestines leading to impairment or complete arrest of passage of contents through the intestine due to pathology that causes a blockage of the bowel. Broadly, it can be classified into dynamic and adynamic. In dynamic, the peristalsis will be working against a mechanical obstruction, whereas in adynamic, there is no mechanical obstruction and either peristalsis is absent or it is inadequate, such as in paralytic ileus. Coming to dynamic obstruction, it can be categorized into three based on the causes, such as intraluminal, caused by fecal impaction, foreign bodies, bezos, gallstones; intramural, caused by stricture, malignancy, intersusception, volvulus; and extramural by bands or adhesions, hernia. Coming to other types, it can be classified into partial or complete. In complete obstruction, there are three types, such as simple, where there is no vascular compromise, and closed loop complete obstruction, in where there is complete obstruction distally and proximally in the given segment of the intestine, as shown in the picture, and strangulated complete obstruction, in where the blood supply to the intestinal segment is compromised, leading to focal or segmental transmural necrosis. And these are the various causes of small bowel obstruction, such as adhesions, hernias, neoplasm, Crohn's disease, gallstones, malrotation, diverticulitis; infections such as tuberculosis, intestinal parasites, hematoma, ischemic structure, intersusception, radiation, and foreign bodies; and various causes of large bowel obstruction, such as colorectal cancer, diverticulitis, volvulus, Crohn's disease, ischemic structure, radiation, hernia, adhesions, fecal infection, and foreign body. Of this, majority of 40% is occupied by the adhesions, followed by 15% of inflammatory causes, 15% by carcinoma, obstructed hernia by 12%, and fecal impaction by 8%. Coming to pathophysiology, in dynamic obstruction, the bowel proximal to the obstruction will be dilated, and the bowel below the obstruction exhibits normal peristalsis and absorption until it becomes empty and collapses. Initially, the proximal peristalsis is increased to overcome the obstruction, but if this obstruction does not get relieved, the bowel continues to dilate and there will be reduction in peristaltic strength, ultimately resulting in the flaccidity and paralysis. There will be fluid loss from the emesis, bowel edema, and loss of absorption capacity, leading to dehydration. And this emesis also leads to loss of gastric potassium, hydrogen, and chloride ions, and there will be significant dehydration, which stimulates the renal proximal tubal reabsorption of bicarbonate and loss of chloride, ultimately resulting in the metabolic alkalosis. And due to the intestinal stasis, which leads to overgrowth of intestinal flora, it leads to development of fecal emesis, and there will be a bacterial translocation across the bowel hole. This ongoing dilatation of the intestine increases the luminal pressure, and when this pressure exceeds the venous pressure, there will be loss of venous drainage, causing increasing edema and hyperemia of bowel. And this leads to compromised arterial flow to the bowel, resulting in ischemia, necrosis, and perforation of the bowel.
Praveen,
Yes, sir.
please stop going at a very fast rate. And secondly, you are virtually reading every word on the thing. What did we teach you? What did you tell you? You should put up bullet points and then elaborate on that. Why are you are reading verbatim sentence by sentence? What is the point of doing something like this?
It will be like just like a copy paste, and you're reading it out.
We can, you just send us the link, we will read it ourselves, or we know where to read it. The purpose of doing this is for you to understand what you are saying, put up bullet points, and then elaborate on those important, sort of specific points on that, rather than just reading out everything.
Yes, sir.
Okay, carry on.
Coming to clinical presentation, the
Wait,
hallmarks.
Praveen. Sir, any questions or comments, sir, till now?
I think
Yeah, there are many. Um, uh, Ravi Shankar, can I add something?
Sir,
Yes,
of
sir.
course.
Yes, sir. Sure, sir.
Dr.
Sir, you
Niranjan.
are
Yeah,
Yes, sir.
Professor, can you, what is your PG's name? Sorry, PG.
Praveen, Praveen.
Praveen, sir.
Praveen, just go to the causes that one chart which you had put. As everybody is pointing, yeah, let's just hold on to this. Hold on to this. As everyone pointed out, um, see, reading like this, it is all given in all books, correct? There's nothing to what everybody will have this list 1, 2, 3, 4, 5, 6, 7, 8 like that. Small bowel obstruction, you are written. You are written malrotation. You are written ischemic stricture. You are written hematoma. All that thing. I understand that you have read how do all these things causes. All right. My question to you is at this stage itself. So I know management classes. I think as somebody told later. If you can tell me, Praveen only, no? Yes.
Yes, sir. Yes, sir.
I will. This is in front of you now. This list. I will just give you a 24-year young boy presents with. Okay, I will give the answer to your mouth. Small intestinal obstruction. Now you just pick up and try to answer this question from your list. Let us put it that way. So in other words, what you also should have added little more is how you suspect in a younger patients. Yes, tell me. Now let me check. Yes, Praveen.
Yes,
What
sir.
are the
You
likely
should.
causes in
Praveen,
24-year-old?
Now
who has come with
Yes.
small bowel obstruction.
I have told you small bowel obstruction. There are some distance that clinically you are not yet reached, but I'm just trying to give you hint. He had a severe pain, vomiting is there, abdominal distension is there. But now tell me in this list.
Uh,
Don't worry,
It
it is a
can.
class for
Come on. Even if you're wrong, you can
Yes.
tell us.
Doesn't matter.
What are the
Yes,
likely
sir. Most
scenarios?
common. It can be due to if there is any previous history of surgery. It can be most commonly it will be adhesion, sir.
Excellent answer. Like
Because
what surgery can you add? That is what Dr. Ravi Shankar, everybody.
Surgery where leg or
sir,
neck.
abdominal surgery,
You have to be
sir.
very specific.
Yes,
Yeah.
sir.
What
So you have to ask, sir.
what everyone was trying to tell you, don't read by heart means, when you told additions there, you should have added that patients with the abdominal surgery. In particularly, can you add something else? Upper abdomen or lower abdomen?
Lower abdominal surgeries.
In lower abdomen, anything particular? Commonest in a young
At
patients.
that age.
Yes. It is appendicectomy, including appendicectomy. You understand, no perforated appendix, pelvic appendicitis, all that, whatever. So
Yes.
there are many causes. We'll talk about later. Yes, I give you full credit. Addition. Now come next.
Okay, what additions you have done? What else?
If patient doesn't have had any surgeries, what is the next
Can
common
appendicitis
cause?
itself cause obstruction, man?
Appendicitis.
Praveen,
Yes, sir. It can lead to intersusception, sir.
not intersusception. Appendicitis.
Don't bring now that.
Don't try to dig. Can appendicitis cause intestinal obstruction?
No, sir.
Why not? If it forms a mass, can it not?
Yes, sir. When there is appendiceal mass, it can, sir. Yes, sir.
Then
You have
complicated appendicitis. Yes.
You have
Then
defined, no, you have defined earlier when we talk about interstitial obstruction can be dynamic and adynamic, correct?
Yes, sir.
In the early part of the appendicular mass, 2, 3, 4 days, as the mass is enlarging, then slowly regressing. Yes, there is a phase of paralytic ileus or whatever, even a mechanical element with paralytic. So it will. So now next, we'll come to the next second common cause. You tell me 5 causes and we'll change that.
see, he's a 24-year-old. You said additions. Can there be something else? He's a young lad.
Next,
Can there be something else?
you have put in the list. I can see one.
Yes, sir.
Tell.
There may be COX TB, sir. Abdominal TB.
Okay,
Sir.
tuberculosis. Okay, fine.
Similar to TB. Similar to TB.
Yes.
See, Praveen,
We have put up.
what we want, in other words, class means this is what you have to try to develop that, So while reading, you say, okay, sir, this could be additions in young patients. Then, yes, come on, tuberculosis equivalent in India, in other thing is, what is the disease in England?
You have put it up, no? Crohn's
Crohn's
disease.
disease,
There.
yes, sir. Crohn's
Anything
disease,
Picture.
sir.
Anything else? Come down, starting from. So we'll start. I will, because the time constraint. Foreign body, small intestine, is it that common? Let us not put it. Radiation, you are written. Where it is common? Radiation. Radiation what? Radiation for what?
What age group? What age group for what radiation?
In the old age, following the surgery for the radiotherapy.
Radiation what, man?
Sir.
What radiotherapy for what? Sir is asking. Why do you give radiation?
It is what I want our postgraduates also in Manipal, also everywhere to understand.
Think. Why? When will you give radiation commonly? In whom you will give?
Sir, in the old age following this.
Not old age
surgery
when
for
we are talking
chemo.
Old age.
about
Why old age? Why young age you won't give radiotherapy? Is it?
We'll give, sir. We'll give, sir. Following carcinoma surgery. Based on
no, not only surgery, man.
Yes, sir.
I think we will probably. So what this is the message I want to convey. So what I'm trying to tell is radiation into strictures, especially for carcinoma cervix and lower down. It is not uncommon. They come after 10, 20 years, but age group is little different. So we are talking about 24 years boy. So like that. Okay, I will give a clue to you. Intersusception has happened. I have given the diagnosis. Patient is 24-year-old. 1 or 2 history is also there. Recurring. What do you suspect? Young patient. Yes, young patients. Tell me. What do you suspect?
What is the
anyone else? Anyone else can also answer.
Yeah, anybody can answer.
Nikita, Vinod.
Meckel's diverticulum.
I have given you, yes, it is possible, but anything else is not recurring. I said I have given the clue, recurring. Okay, it's Nikita or whoever it is there. So this is how you can stimulate the interest in all these people, and these PGs have to come like that. So what I wanted is a pure polyposis. Some polyps.
Jaeger syndrome.
Jaggers.
So I will quickly tell him what Praveen. So in other words, you should be able to pick up hernia. Yes, you should never forget obstructed hernia, even in a young patient. Okay,
yes,
so
yes,
you are written Crohn's here, that's okay. Gallstones. Suppose I ask you, in what way gallstone is related to small bowel obstruction? What is the answer? Young boy or some 40, 50-year ladies? What?
It can be in any age group, sir.
No. Common, you tell, man.
Common,
what is sir asking? Commonly, in what age group you will see? And how can gallstone produce obstruction? That is what sir is asking.
So if you are able to develop that understanding, that is what this is the worth of that, whichever class. Yes, tell me quickly.
It's
yes. Come on, try. Don't worry. Somebody has written old.
If Praveen can't answer, Nikita or Vinod, anybody can answer.
Sir, fistula formation.
Somebody wrote, sir, old age slipped stone. Don't say that.
Fistula formation.
Somebody.
How will fistula cause obstruction, man?
No, sir. Fistula leading to slippage of stone from through the fistula into the distal ileum, where it can obstruct.
What is the one?
What is it called as?
Yes.
Gallstone induced ileus, sir.
Correct.
Gallstone ileus. The meaning of the word ileus means to stop. That's the actual ileus. Stop like that. So malrotation also to be considered. Praveen. So
yes,
because
young patient,
he will come with the recurrent abdomen. So we are talking about younger. So the homework for you is, suppose I say 45-year-old female, 50-year-old female. Make list of 3, 4. So like that, group it.
What Professor Shana is saying is, whenever you make the list, you should be able to compartmentalize it in, if it is a young male, young female,
Yes, sir.
middle-aged person, elderly people. So you should be able to then, prioritize what are the likely causes. It's not that
Yes.
a old age person will not have these problems, but it is less likely. So that is the purpose of having a list like this, and then you are able to. So that is what is postgraduate learning is about, not just
This
putting a
this
list.
chart anybody can search in Google and find out, but you should know when to apply
Yes.
and what to diagnose. When you're like a consultant, when you become a consultant, or even now when you're on duty, if a patient comes in, you can't have all these diagnoses. You have to shortlist and come down to a differential diagnosis. So you should be knowing when all this can happen and whom all it is common.
So that will
Yes, sir.
improve their thinking capacity so that they will further do a correct examination.
Correct.
I think we can proceed, sir. I think we
Yeah,
proceed.
see, Praveen, what
Yes, sir.
eyes do not see what the mind doesn't know. See, if, for example, the diagnosis is staring at you, if you don't know what it is, then you will not be able to diagnose it. So that is why it is important to have this kind of, analytic thinking rather than just, copy pasting from some book and, reading the list. It won't help. Okay, carry on.
Nikita, it is not old age. It is there is a common this thing, no, fat, fertile female. So
Yes, sir.
gallstones are more common in females, especially in the reproductive age group between the 25 to 45 in that age group.
Okay, sir.
So
Okay,
I
carry on,
hope you
sir.
all series will make a list of yourself and say make causes in a different way. This is the statistical analysis. Whatever this slide, whatever is showing is worldwide, more common like adhesions, all that thing. Yes, please go ahead.
Praveen, the other thing
Sir,
is
yes, sir.
what Sir said about malrotation. It can also, indicate, congenital bands. So that is also, 24-year-old, a congenital band is also common. Malrotation of the gut is also common. So these are things you should be able to say whenever somebody of that young age comes, you should be able to 4 or 5 important causes for intestinal obstruction. Okay.
Yes, sir.
Continue.
Sir, here,
In, is-
since you are,
Yes, sir.
management is in the next class, no? Correct?
Management
sir.
is in next class. Dr. Lakshman will be presenting apparently.
So this you should have explained much more, sir. This hallmarks. Can you explain about
Next.
colicky pain, each one of them, vomiting, distension, all this little more? Can you explain, Dr. Praveen? No, yes.
Yes, sir. I'll be explaining now, sir.
Okay,
Yes,
sorry.
sir.
Yeah. Carry on.
Intestinal obstruction, the hallmark presentation of obstruction is colic abdominal pain, nausea and vomiting, abdominal distension, and cessation of flatus and bowel movements. There is slightly variation between the presentation between small bowel and large bowel. In the small bowel obstruction, the abdominal pain will be intermittent and colicky, and the pain release with vomiting. But in large obstruction, the abdominal pain will be continuous. In small obstruction, vomitings will be of more frequent in larger volumes and bilious, and it occurs before the constipation. But in large bowel obstruction, the vomiting is very less prominent. It will be intermittent and sometimes feculent, and most commonly constipation occurs earlier prior to the vomiting. And palpation, tenderness will be focal in the small obstruction, most commonly at the central and mid abdominal, while in large obstruction it will be more diffuse, more in the lower abdomen. Large bowel obstruction can mimic as small bowel obstruction when the ileocecal valve is incompetent, so that it can allow the insufflation of air from the large bowel into small bowel and produce same symptoms as that of small bowel obstruction. And in the auscultation, during the early obstruction,
I mean,
there will be
if the valve is competent, then what will happen? What is that kind of obstruction called as? Large valve obstruction. If the ileocecal valve is competent, what will happen? What is that kind of obstruction called as?
You said that before. This
You,
is why
you
I feel
yourself told.
This is why I feel you guys are just copy pasting without understanding. What you said something,
Yes,
no,
sir.
closed loop
Closed loop.
Yes, sir.
obstruction.
Closed loop obstruction. Yes, sir.
Then why are you not able to
You
say
all,
it
you
now?
yourself told type of obstruction.
Yes,
Yes,
sir.
it is. So it is closed loop obstruction. What is the danger in closed loop obstruction?
So,
What
it
happens?
commonly leads to increased pressure and perforation, sir.
Where?
Of what?
So,
What?
bit
Think when if large bowel is obstructed and there is a ileocecal valve which is competent and obstruction is there. So what happens over a period of time? It
Nikita, where is the
dilates.
perforation less, this one, most dangerous? Where does it happen?
splenic flexure, sir.
No,
No,
man.
Sir, it
I
will
think we
be
discussed in the last but one class
Last.
when we were discussing. I think Ravi Shankar sir himself had told about it, and you people mentioned also.
I think Praveen,
sir.
splenic flexure growth may be there, hepatic flexure growth may be there, but what perforates when the ileocecal valve is competent?
Competent.
Full answer.
Very simple, man. What is called
Nikita,
butt
Vinod,
of the gun? What is the butt of the gun here?
Does appendix perforate, sir, in that case?
Not appendix, man.
no man.
Where is
Cecum,
appendix attached to?
cecum,
Cecum.
cecum perforates. We discussed it just in the last class where you are presenting a case, no, of that tumor. Ravi Shankar sir himself told about the
Cecum is
diameter,
thin.
everything.
Yes, sir.
Cecum is thin walled, right? It is not as thick as the left colon. And so cecum is the butt of the gun. So cecum perforates most commonly.
So I think they examiners expect a little more. Let them prepare, sir.
Correct.
Laplace formula, diameter of the cecum,
Correct.
Yes,
Yeah.
sir.
inward structure. Like you can tell them, you like your happy birthday balloon, you blow it, ruptures thin walled. So like that, appendix doesn't perforate. So it's a cecum. Okay, it is a very favorite question. This closed loop. I will ask one more question. Think like that in the large intestine. Where else you get this kind of a picture of a closed loop obstruction in one organ? Not carcinoma or something. Something happens. Yes.
Valvular, sir.
Yes. Very good. Valvulus. So the sigmoid. Say,
Sigmoid volvulus.
when turns, actually both ends get obstructed. Correct.
Obstructed. Yes,
It
sir.
is also a closed loop obstruction. That's why you get an enormous distension, both with the gas,
What is
carbon dioxide.
what is that sign called as classical X-ray?
Coffee bean
No.
sign, sir.
Bean.
Yeah, coffee bean.
Coffee bean appearance. Okay.
Yes, sir. Shanai, sir.
Continue, man.
Yeah, I think some more points. Just go to that pain abdomen slide because we are only.
Go back.
Yeah, just whatever you have told, intermittent, colicky, everything fine. But see, you should tell no. You have written tenderness in the central and mid abdominal. So they also hold the which area is the where patient will show you intermittent colicky. Where they will show site very important. Is it gastric below the xiphisternum or mid? Where? Small bowel.
Praveen,
So, in the periumbilical regions.
Yes. So it is a central abdominal. That word should come because these are some of the small tips. You at
Yes,
that
sir.
time when patient is showing you that umbilical area have got some pain or something, also look at the umbilicus. Sir, this is a little additional point. If there is some deformity in a young boy, because I have seen one, it could be a Meckel's diverticulum with a VI duct anomaly. VI duct anomaly, but vitello intestinal
Intestinal
duct
duct.
with
Yes.
some kind of a deformed umbilicus. One patient I had with a small obstruction. I did not realize that. Later I found that inside there. Anyway, central abdominal pain, colicky pain comes and goes, and that severity improves. Improves with vomiting means once the
It relieves when the vomiting.
one other thing other than this continuous and all that thing. What is the meaning of the word feculent? That's what I want, because you put it on the large bowel obstruction.
The
What
fecal material
no,
will be
no. Then you
No, it is not fecal matter. Then it will be fecal matter. It is feculent, the term. It is like fecal matter.
I don't know where you got this table, that word. If you have done a copy or something, I maybe. But what is the actual word feculent means?
What does that mean, man?
Fecal matter like smell, but
yes.
There is
It
case
will be collected old bile, which over a period of time will mimic fecal matter. That is called as feculent. That smell.
cases with bacterial overgrowth causing the smell. That is the word meaning.
So classically, this word feculent means terminal ileum for a longer period, and that warrants that time is a decision for a clinician. Irrespective of feculent means it is definitely a older obstruction. Today we have got everything, but CT scan, this, that. So feculent is the fermentation, that smell, basically smell. The color is little thicker than the bile. So that's why this is a gross error according to me. Ravishankar and Niranjan, I think so, correct?
Yes, sir. Yes,
So
sir. Correct, sir.
this should not come feculent on the large bowel. Tomorrow everybody will tell, looking at this slide, sigmoid colon obstruction, they will feculent like that. No, it is not like that. Okay,
Yes, sir.
right, Praveen?
Yes, sir. Yes, sir. Understood, sir.
Then tenderness. Can you describe why is that tenderness there? Focal, central, mid-abdominal, more diffuse. When do you get tenderness?
What is the significance of tenderness, man? As a surgeon, if you find tenderness, what will you do?
In a case of obstruction, if there is tenderness, what should you do? Will you conservatively manage, or will you do something else? Why your alarm bell should raise when there is tenderness? Why?
Sir, when tenderness is there, then there may be perforation peritonitis, sir.
One thing
Not
is
only perforation peritonitis, it is a sign of strangulation.
Yes, sir.
So, ischemia.
Sir.
So you have to intervene in those cases urgently rather than waiting.
Yes, sir.
Please, see, try to understand which everyone is, what exactly is telling you. You have to understand, we are talking about mechanical obstruction. This is not paralytic ALS by definition, whatever you have written. You understand, no?
Yes, sir. Yes, sir.
Mechanical obstruction patient. One small distended loop, when you press, there could be pain. Remember, tenderness and palpation and versus rebound tenderness. Which is more important?
Rebound tenderness is important, sir.
Why? It's difficult,
Sir.
tense abdomen sometimes to elicit all these things. Yeah, what does it reflect? What does it reflect?
Sir.
If there's a
Reflect when there is rebound tenderness in appendicitis. What does it reflect?
Yes.
It-
Don't think you are palpating appendix and patient is getting rebound tenderness. Yeah, peritonitis. Somebody
Nikita, you can talk. So it's a sign of peritoneal irritation.
Localized peritonitis.
So
Localized peritonitis, sir.
yes, correct. Abdominal pain. So vomiting you have written here. Then focal and central and mid-abdominal tenderness. This is a large bowel obstruction, more diffuse, whatever you have. Tenderness generally, indicates a real strangulation, as has been already pointed. Large bowel tenderness is, we don't relay it because large bowel to become so much, it takes some more time for it to become. All right, sir. Anything? Next we can move, I suppose.
Okay. Praveen, move on.
Yeah, this I think has been. Hey, 1 minute. You have moved to, since we are still in the clinical side. Did you mention peristalsis, man? You should mention. If you have moved auscultation already, you have gone. As a PG, you should look
I
for.
think he has not mentioned.
You should,
Yeah.
Yeah, you should spend some time. Okay, Praveen.
Yes.
Whatever. Don't neglect clinical thing. Ultimately, you will know ultrasound, X-ray, everything is different. But just spend 5 minutes, you will get. Sometimes you can get a real, distended loops. It may not be classical, but thin patient emaciated, you may get. Right?
Yes, sir. Yes.
Did you we have to mention hernial orifices as a clinical examination and everything. All right. Vowel sounds, high pitch sounds. Yes. Okay.
You should check for one of the commonest this thing missed. This thing is femoral hernias.
Yes.
You should check all the hernial orifices if there is whenever there is a case of obstruction.
Yes, sir.
Especially in elderly females, the femoral hernia is very commonly missed. So you have to palpate very carefully under the inguinal ligament to see if there is any lump there, which is why you have to undress the patient with the chaperone under good light. You have to examine these patients.
Yes, sir.
There should not be any hesitancy to check. Okay. Next,
Carry on, ma'am.
Praveen. Carry on.
Yes, sir.
Yeah.
And with the same symptoms of abdominal pain, distension, nausea, and cessation of flutters, there may be the alternate diagnosis,
Why did you
which may be
bring this ascites and I don't know, acute liver failure? What is this? That for abdominal pain, is it? DD. Where do you get
No,
this?
he's talking about DDs for intestinal obstruction.
with same
When you are
symptoms
suspecting.
of
You're talking about differential diagnosis
yes, sir,
for
differential
intestinal obstruction,
diagnosis.
right?
Yes, sir.
Yes.
Yes, sir.
So tell us what will be the difference?
Ascites can present with distension and nausea.
What will be the difference?
Sir,
how will you diagnose ascites, man? That is what will be the difference?
In ascites, bowel sounds will be present.
There can be.
What
is a clinical sign?
Shifting dullness.
Shifting dullness, yes, sir.
Fluid thrill.
Fluid thrill, shifting
Fluid
dullness.
thrill, yes. And also you put up acute liver failure. What else will be there? Sign.
Sir, I think he should not get confused. Whatever be the book which you have taken doesn't matter. See, patient's complaint is severe abdominal pain. Yes or no, Praveen?
Yes, sir.
So now first target that. So in that list, if you see carefully, mesenteric ischemia is also one of the DD for a intestinal obstruction. You know that?
Yes, sir.
You know that? Intestinal. So anyway, I'll take it. Perforated viscous, definitely. Post-operative paralytic ileus. Pseudo obstruction. All this can be discussed more. So these ascites, if you are telling it is for distension, correct?
Yes, sir.
Ascites, if there is spontaneous bacterial peritonitis, then you will have pain.
So that is
SBP.
different. Okay.
Yeah. SBP with probably cocooning of the intestines causing obstruction. Then you will have that. Otherwise, usually ascites will not have any pain.
Yes, sir.
So you should not, I don't know where you, differential diagnosis of a abdominal pain, distension, nausea, cessation, flatus, beaver. What is that title?
The title is wrong. It is differential diagnosis in a case of intestinal obstruction. And that ascites actually should come last.
That's what I wanted these people to realize. So painless distension, that one based on one criteria you have taken. So, but see, medicine, so many things can happen, but it's a different issue. So try to understand whenever you prepare your presentation, what does ascites produce? What does this tricyclic antidepressants, what do they produce? Can you tell me? They can produce obstruction, but what type of obstruction is that? You have written there little below.
Is it dynamic or adynamic?
Last he has written also something.
Adynamic. That is pseudo obstruction. That is pseudo obstruction.
You have heard of large bowel
or paralytic
obstruction, fecal impaction? Fecal impaction.
Yes, sir.
You know, elderly people, you have mentioned elderly people, one of the common problems you get that antidepressants, motility issue, and written there Ojlivi, that is comes in the large bowel, pseudo obstruction.
Yes,
It
sir.
is
Yes, sir.
a
Acute
1 hour.
colonic pseudo obstruction.
It itself is a 1 hour topic. Okay, for
Yes,
you,
sir.
for PGs should read. So in other words, when there's abdominal pain is dominating, you should try to understand. Yes, perforated viscous, definitely 100% true. You understand? I think
Yes, sir.
we should have also given acute pancreatitis. I don't know where, because why acute pancreatitis?
Praveen,
There will
answer.
be severe pain, nausea,
See,
sir.
Correct.
No. Why? In that
Sir,
case, what
vomiting.
happens?
Vomiting,
Sir,
yes.
Both patients go into paralytic ileus.
paralytic, yes, sir.
you
And
have,
also
you have put
third
the
space
title.
sequestration of fluid.
You have put the title there. Everything matches to acute pancreatitis. What is
Yes, sir.
sentinel loop? What is sentinel loop? You heard of that? Sentinel loop, big dilated jejunal loop sign.
Colon cutoff and sentinel loop
Yes.
signs.
Yes. So sequestration of fluid. So in other words, mesenteric ischemia, okay, it's a part of it's obstruction. Perforated viscous, acute pancreatitis. Yes, postoperative. Somebody has undergone cesarean section, comes after 3 days, 4 days, continuing. So there where comes all these things. Then
Yes,
OGLV is a pseudo obstruction. Yes, sir. That's all from a little bit from my side. Yes.
Yes, sir.
Praveen, did you understand what
Continue,
sir was
Praveen.
telling you?
Yes, sir. Yes, sir.
This is again the folly of copy
You
and
should
paste.
think.
Copy and paste. You have just pasted some list from somewhere without actually thinking about what you are actually putting up.
And the title what you have put up is also wrong. Differential diagnosis of intestinal obstruction, all this. But in that you should think which will come first, which will come last.
So
Yes.
mesenteric ischemia, perforated viscous, acute pancreatitis, postoperative ileus. These are the 4 things you should mention.
Yes, sir.
Pseudo obstruction, ascites, and medication is medical causes for causes for intestinal
Which
obstruction,
mimic
which we may not need to necessarily treat.
Yes, sir.
Okay, carry on.
And in ascites, in tuberculosis also you will get ascites. You are not mentioned. That is a more common this thing than hepatitis if they present with obstruction. If there is ascites.
Okay, sir.
Continue, man. Why are you just
Coming to individual causes, adhesions is the most common cause of intestinal obstruction, and the various causes of adhesions are acute inflammation in when there is at the site of anastomosis and in the areas raw areas of reperitonealization, and when there is area of ischemia due to foreign material, and in infections such as peritonitis and tuberculosis, and in chronic inflammatory conditions such as in Crohn's disease and in radiation enteritis, there are other major causes of adhesions.
so in today's scenario,
Sir,
Praveen, in today's scenario, which
sir.
are the things you would actually cross off from the list?
Foreign material, sir.
What foreign material?
Gauze.
Gauze we
Talc.
still use, but we
Talc,
don't use
sir.
talc.
Yes,
The
sir.
powderless gloves are there, so talc is no longer an issue. Silk
Yes,
is
sir.
hardly used, so silk will not because we are now moved on to other suture material, so silk is hardly used. Again, radiation enteritis is still coming now because people who have undergone radiation last 15-20 years ago may still present with this one. But the newer modalities of radiation like the IM, intensity modulated
MRT.
and image modulated, image guided radiation, the incidence of radiation enteritis will come down enormously.
Sir.
Radiation enteritis, 2 ways. One commonest is strictures. Second, due to adhesions. Radiation enteritis can also produce strictures.
So just for a Praveen only,
Yes,
this
sir.
list, nice list. whatever little bit adjustment you have to do. First is, I will tell you, first is say infective. What is infective in this list? This is only for Praveen. Infective. You are written there.
Tuberculosis and peritonitis.
So have the, no, what I'm trying to tell is the peritonitis, any appendicitis, remember always pelvic pathology first. Always remember.
Yes, sir.
Appendicitis, ileal perforation, like enteric.
Okay. Then next I will give you after infective, inflammatory. Can you tell me the list? You are written there.
Crohn's disease.
So that is one of the
Condition.
things because inflammatory, when we say generally in tuberculosis, we put it in a different inflammatory is over. Now next, very, very important is ischemic. Ischemia is one of the very strong factors to produce multiple adhesions. Ischemic bowel. You are written there, but you have just put it under acute inflammation. See, eventually ischemia also produces, damage and all that thing. But remember, ischemia per se is a separate, very important entity. All that you are written there, acute inflammation, in that category you have put site of anastomosis. So do you do reperitonealization? I hope you understood the meaning of that word.
Yes, sir.
What?
So, when there is two adjacent raw areas.
So if you try to pull and reperitonealize, no. That confuses. That I think that produces more adhesions. You understand?
Yes,
Whenever
Yes,
you
sir.
cut the peritoneum and you left it open, or whenever it reperitonealizes, then it causes more adhesions.
Yes,
So now,
sir.
so what did I tell you? This inflammatory, infective. Then comes iatrogenic. What is iatrogenic? Yes.
That
It is
which
there.
was done.
You are written.
Sir,
Not at all. Not
foreign material talc. Yes, sir.
so including
Silk.
talk just now has been cleared. Silk.
Yes, sir.
Foreign body. Remember this
Yes, sir.
iatrogenic means when we say foreign body means even today, with all the things, mops, gauze pieces are still retained. Right. Next,
Yes.
irradiation structure. Where is it? Your radiation enteritis. So you can remember inflammatory is there, right?
Yes, sir.
Infective is there. Inflammation is different. Infective is different.
Yes, sir.
Iatrogenic is there. Irradiation is there. Okay. So
Yes, sir.
in other words, so you can just make a list of that. These are ischemic. 5 major groups. Okay. Right.
Yes.
Please go ahead.
Coming to bands, bands can be due to congenital, that is obliterated vital intestinal duct, or LAD bands. LAD bands is it arises from the cecum and it extends to the subhepatic and posterior peritoneum, and it may compress the second or third part of duodenum, and it can cause a small bowel obstruction. And other cause of bands might be a string band following previous abdominal surgery or due to peritoneal inflammation.
So yeah, since you have mentioned that peritoneal inflammation, I think all, including tuberculosis, any surgery, even if a patient does not have a scar in the abdomen, he can have inside the abdomen adhesions.
Yes, sir.
So it is not necessary that only, that's why it solves that peritoneal inflammation, one word is there. It can be even in acute pancreatitis, may not be very strong bands like that, but especially pelvic appendicitis, ovarian, females. Remember this very important thing. Females, especially female. So
Yes,
even a tubectomy can cause that. Tubectomy side bands can get formed and produce obstruction.
Yes, sir.
Yes, go ahead. Yeah, I think this is about the bands. Yes.
Intersubception, it is the invagination of one segment of bowel into an immediately adjacent segment of bowel.
I hope
It contains
each one of them are big topics for you, but each one for a PG level I'm telling, but you can go ahead, no problem, please. Yes. Go ahead.
Yes, sir. Intersubception mainly consists of 3 parts. That is the entering tube or inner tube, which is also known as intersubseptum. This is and the returning or middle tube, and the sheet or outer tube, that is intersusceptions. Intersusception is most common in children, and it is the second most common cause of intestinal obstruction in the children after pyloric stenosis. And it is usually at the age of 6 to 8 months with a male predominance. And in children, ileocolic intersusception is the most common form. And in pediatric age, the intersusception is usually idiopathic, with only 10% of cases having precipitating lesions such as Meckel's diverticulum, polyp, appendix, or inert colon purpura. And in children younger than 2 years, they'll classically present with acute onset colic abdominal pain, knees drawn to the chest, and excessive irritability and crying. The stool will be mixed with blood and mucus, which gives current jelly appearance, that is red jelly appearance. And on the physical examination, we can palpate a sausage-shaped mass in the right upper quadrant or in the epigastric of the abdomen, but it is only detected in approximately 60% of cases only.
So just hold on. Praveen, this
Yes, sir.
this slide only, since
Yes,
Dr. Ravi Shankar pointed it earlier, what you should tell here, that one bullet with, you don't have to write here knees drawn to the chest, all that thing. Whatever be the child's attitude, or you don't call attitude, rather child's condition at that. Second, you just say current jelly stools. You explain. Third, sausage shaped mass. Where it is felt, you have written there epigastric region, umbilicus mass, only detected approximately. What is the shape of that? Sin AD dance. I don't know whether it comes or not. So you put a small figure there, umbilicus, and draw one picture. Sausage shape, convexity towards this. See, you just put some bullets and put some 5 lines and you explain. That is how
Yes.
you improve. Okay, I suppose.
Yes, sir. Yes, sir.
So Ravishankar sir, you're asking something, sir.
Yeah, why can you only detect this mass in only 60% of the kids? Sausage shaped mass. Think about that, Praveen. Anybody else?
No.
Nikita? Sanya? See, the child will be continuously crying because of the severe colicky abdominal pain. So when the child is crying, the abdominal muscles are under contraction. So you will not be able to feel the mass. So only when you sedate the child, giving the child painkiller and making the child relax, in such people you will be able to feel and if the intersusception is not large enough, you may not be able to feel it, which is why it's only felt in about 60% of people. If
Yes.
it's all very logical, if you think about what is the pathophysiology, you will understand. Okay, carry on.
Contrary to the pediatrics, in adult intersusception, there 90% of cause is identifiable and only 10% are idiopathic, and colocolic intersusception is the most common. Likewise, in the pediatric intersusception, there won't be any, the presentation will be non-specific, and most common presenting symptom will be the abdominal pain associated with partial obstruction symptoms such as nausea, vomiting, obstipation, change in bowel habits, constipation, or bloating.
Just hold on. You are coming to that causes. You are showing. I think next slide.
Next slide is, sir.
Okay. Please.
Next slide.
Yeah. Correct.
Causes can be benign and malignant, and these are the various causes that triggers intersusception in the adults.
Praveen,
So,
in
yes,
kids, when there is no identifiable cause, what is the likely reason why they develop intersusception? It is said the Peyer's patches hypertrophy
sir.
of Peyer's patches.
Hyperplasia. Yes, sir.
So that causes the focus of the intussusception. Okay.
Yes, sir.
Praveen, in this,
Sir.
rather than just putting those causes, you should tell us which is the commonest.
Yes. So I always tell these people think because ultimately the list is available with everyone. So you should think, and even at surgery, you should know how to make a feeling. Yes, tell the common. Yes.
Common would be the Crohn's disease and Peutz-Jeghers polyps, sir.
Crohn's, very rarely.
Crohn's, very rarely they present with intussusception, man. They present with strictures.
They have
Sir.
transmural inflammation. The bowel is very thickened. There is no chance. It's not supple bowel. So very, very rare to intussuscept. Have you seen intussusception, Praveen?
No, sir. In the
The
Crohn's
bowel
disease.
loops they are very soft and supple. Not like Crohn's disease where there is transmural inflammation, mesenteric fat creeping. So the bowel, that kind of bowel is very unlikely to, undergo intussusception. So Crohn's disease is not one of the common causes for intussusception.
Commonest will be polyp,
Yes,
followed
polyps,
by
sir.
probably Meckel's diverticulum and lipomas and tumors. Sir,
Yes.
am I correct?
Again, tuberculosis also is very uncommon to cause intussusception.
Unlikely. The tuberculosis and Crohn's, they most of the times they present with strictures
Pictures.
and obstruction rather
fibrosis,
than intussusception.
thickening.
Shanai, sir?
I think wherever anything which involves a lot of fibrosis will not produce intussusception, sir. Fibrosis, the luminal, that stricture, this, that, Whereas if you see, this polyps, lipoma, neurofibroma is written. I don't know where neurofibroma. See, theoretically, everything is possible. Lipoma, definitely, yes, inflammatory polyp. What is inflammatory polyp? Just for curiosity, I'm asking him.
Sir.
What is inflammatory polyp? How do you classify polyp? Because this is how the examination. In that, there are many.
Whatever you put up, you should be knowing about it rather when you put
Yes,
it up.
sir. It is non-neoplastic projections of mucosa, sir.
On neoplastic. So what is hematomatous polyps? What is inflammatory polyps? What is hyperplastic polyp? What is neoplastic polyps? Any idea? So little bit reading. Okay. So please,
Yes,
see, I don't know whether you get inflammatory polyps. Of course, it has to be correct. Yes, taken from standard books. Sir. Hemangioma, hematoma, gist, yes, definitely, sir. Gist that we have seen the LSC career. Endometriosis, how does it cause? I mean, there are so many things. The list is very big. Carcinoid tumor, enteric malignant, he has written there. Correct. We have. Do you use the word carcinoid tumor or something else? Only carcinoid syndrome. For the tumor, I think you should change the word. What is that? Yeah, Praveen, no? Praveen.
yes, sir.
Praveen,
Yes, sir.
Net.
What? No longer called carcinoid, man. What is it called?
Net. What is net?
Neuroendocrine tumors, sir.
Neuroendocrine tumors, yeah.
Syndrome is used. Okay. So I
Yes,
think lymphoma, yes, list is quite big. Yes, theoretically, definitely everything is possible. Anything irritating that area, that especially either it's ileo. Okay, I forgot to ask him a question. What's called compound intussusception, retrograde intussusception. Whether we asked that he has covered. What is retrograde intussusception, Praveen? I think we have seen, but probably your generation. Retrograde. That means normally it is a proximal to distal. This is a reverse. When it can happen? Yes, it can be quite dangerous because it happens most of the time. That goes for gangrene. It's following a GJ. Okay.
Yes, sir.
Gastrointestinal, whatever be the reason.
Yes, sir.
People used to live longer after the Vilgatum GJ. Once upon a time, we used to do. So they come after some time with the. So nowadays, probably these people do not see. Yes, Ravishankar, that from little bit from my side.
Yes, sir.
Yeah, continue, man.
Continue, Praveen.
Volvulus is a twisting or axial rotation of portion of bowel about its mesentery, and it causes obstruction to lumen when there is about 180 degrees torsion, and when there is 360 degrees of torsion, there will be vascular occlusion. Primary volvulus is commonly due to congenital malrotation of gut, abnormal mesenteric attachments, and congenital bands, such as in volvulus neonatorum, cecal volvulus, or sigmoid volvulus. Secondary volvulus will be due to the rotation of segment of bowel around an acquired adhesion or due to stoma. It can be presentation can be of two types. In fulminant, it will be of sudden onset, it's severe pain, early vomiting, rapidly deteriorating clinical course. While in indolent, there will be insidious onset, slowly progressive course with less pain and late vomiting. Coming to cecal volvulus, it can be a part of volvulus neonatorum or present as de novo, and it is usually clockwise. It is more common in females in 4th and 5th decades.
Wait, Praveen, sir. Sir wants to leave, I think.
Thank you, sir. Thank you so much.
Shanai, sir. Thank you, sir.
Not that
It was a very good, your inputs and all.
10
Fine.
o'clock happened, but in it, class means, see, each one of them are important from PG level. Cecal volvulus is something which is very, very important in a sense for PGs. I don't, because there are many things we can speak. What is, bascule? You heard of the term, this Praveen, no?
Yes, sir.
Bascule. Do you know that word? Cecal volvulus occurs part of volvulus neonatorum. Okay. Sir, maybe some other time I will take one class with the case-based 3 or 4 cases of intestinal obstruction.
Yes, sir. That will be better.
Yes,
That
sir.
will be better.
So after 2 classes, just inform me some
Yes.
2 weeks before I will take.
Sure, sir. I will ask our registrar to coordinate with you, sir.
Yes.
Probably next month we can plan it and post it, sir.
Thank
It will
you.
be
Sanya.
very helpful.
Yeah, please,
Sanya.
go ahead. Yeah.
Sanya,
Yes, sir, yes, sir, yes, sir.
lecture.
Yes, sir, okay.
Guest,
I'll put
guest,
it
lec-
next time.
guest lecture
Faculty
or
guest lecture.
group discussion.
Okay, sir,
Yeah,
okay.
either
Yes.
group discussion or faculty lecture. Yeah.
That is fine, sir.
Okay,
No,
sir. Yes.
Thank you, sir. Thank you very much, sir.
thank you.
Praveen, continue.
Sir, initially, the obstruction will be partial with passage of flatus and feces. Around 25% of cases, on examination, there will be palpable tympanic swelling in the midline or at the left side of the abdomen. And the volvulus result in the cecum volvulus, the cecum will be lying in the left upper quadrant. In sigmoid volvulus, the symptoms will be of large bowel obstruction, and the abdominal distension will be the first symptom early, and it will be progressing, associated with hiccup and retching. Constipation is absolute, and it is in elderly, the more chronic form will be seen.
Where is sigmoid volvulus very common, man?
Sir?
Sigmoid volvulus is very common in one set of individuals.
Sir, in Black African populations.
I don't know whether it's Black African, but certainly one is you mentioned elderly people. Second one is for some reason it is also common in amongst the people with
High fiber.
intellectually mentally challenged individuals, people with Down syndrome and all this they for some reason they tend to be very constipated, I think, or their medications that they take will cause chronic constipation, which leads to sigmoid volvulus. So, and that is mental, the patients who are on medication for psychiatric and mental disorders and people who are mentally challenged, I think they have high incidence of sigmoid volvulus.
Okay, sir. Coming to compound volvulus, which is a rare condition also known as iliosigmoid knotting. In this, the long pelvic mesocolon will allow the ileum to twist around the sigmoid colon, resulting in either the gangrene of ileum or other the sigmoid bowel, and patient present with acute intestinal obstruction, but distension is mild. In plain radiography, there will be distended ileal loops and in the distended sigmoid colon. Coming to imaging of these various subsections.
How many
Plain-
slides have you got, man?
Sir, another 10, sir.
Okay, finish it.
Plain radiographs will be the initial imaging modality for the suspected obstruction. And in the plain radiographs, small bowel has characteristic circular folds, that is placa circularis or valvular conventins, which appear as thin lines in the entire diameter of the small bowel. In large bowel, there will be haustral folds, but it does not span entire diameter of the bowel. Generally, the small bowel will be in the centrally located and colon is peripheral. Here
Does it
can
suggest? Yeah, continue.
So the big
Yes, sir.
large arrowhead shows what, man?
It is a small obstruction, a small bowel obstruction, small bowels
Large
showing the
arrowhead. Large arrowhead.
large arrowhead is a small bowel which is located centrally, and there is plica
Hello,
circularis.
man.
Sir.
Large
Sir.
arrowhead.
This one, sir.
What does
This is large bowel obstruction showing horstations, sir.
That is horstations.
Yes, sir.
The small arrowhead shows.
Why do you say it is a large bowel obstruction? Why not ogli?
Sir, it is located peripherally, and you can see the horstations.
No, I'm asking, how are you
sir.
differentiating it from a paralytic ileus or a ogilvy syndrome, pseudocolonic obstruction?
So this can this not be pseudocolonic obstruction?
Yes, sir. It can
Why do you
present,
say it is large bowel obstruction?
Is there gas in the rectum?
So this picture is not
sir.
proper. When you're taking X-ray, you have to expose the full pelvis there to see the rectal air shadow. If there is air in the rectum, then if there is gas in the rectum, then it is not a large bowel obstruction.
It is
Then it is an
Paralytic.
obstruction or paralytic ileus.
Yes, sir.
What is the arrows which you're saying there?
This thin arrow shows plica circularis showing that it is small bowel, and thick head arrow is showing that it has hastations. It is a large bowel, sir.
Praveen,
Yes,
are
sir.
there ileal loops in this also?
Can you see ileal loops
Yes, sir.
anywhere?
Are there any
Where?
ileal loops?
No, sir.
Of course there are.
There,
Show that.
you go. RIF, you go.
See, there characterless
Those are all.
is ileal
Those
loop.
are all ileal loops. Without ileal loops, how can you have that large bowel
Yes.
obstruction then? Then
Yes,
it will be
sir.
segmental obstruction.
See, what is characterless, man?
Ileum, sir.
Ileal loops to have no character.
Yes, sir.
Just be gaseous distension of the bowel. For example, jejunal, as you said, will have valvulae conniventis, and large bowel will have horstations.
Yes, sir.
Okay. Next.
Abdominal radiographs can be obtained in both dependent, that is supine or prone position, or non-dependent, upright or decapitated position. In supine positions, due to gaseous distension, there will be stretching of the plicae, and it can be seen visibly as stretch sign. And when there is when the bowel is fluid filled, the small pockets of gas will be trapped between the plica circularis, and it can create multiple air fluid levels, which appear as string of beads. On upright or decapitated radiographs, there will be multiple air fluid levels, or air fluid levels can be wider than 2.5 centimeter, or two air fluid levels within the same bowel loop at different heights, which suggests there is a stepladder pattern. And,
how many normal fluid levels are there, man? Air fluid levels?
Sir?
When you see X-ray, how
sir.
many if you see levels, how many of them are normal? If you see one or two or three, when you say it is abnormal?
More than 3 is abnormal.
That is what sir is asking.
Yes, sir. More than 3 air fluid levels will be abnormal, sir. And this is a step ladder pattern seen
What
in the
are those
both
three?
X-rays.
What are those
Sir,
three?
sir,
That is what sir asked.
jejunal, duodenal, and gastric, sir.
Sir,
Gastric bubble, is it considered as one? Is that considered as part of the thing? I think gastric S1 is, separate. One is duodenal, you're right. The other one is
Jejunal, sir.
jejunal. How can it be
Sir.
abnormal? Normal, man. Ileocecal
Sir.
valve. That is another.
Okay, sir.
I think maybe considering fundal gas bubble is also, so that will be 3.
fundal is also considered. Fundal
Yeah,
is considered as one of the levels
one
of
of the so
gastric abdomen.
so fundal, duodenal, and the ileocecal.
Ileocecal. Yes, sir. And the twisting of colon around a narrow or elongated mesenteric pedicle can show a U or C-shaped appearance, commonly known as coffee bean appearance. And concavity will be pointing towards the site of fist. In sigmoid
Praveen,
will be left side.
I told you the other day. Also, see, you're all reading through the every slide, every this thing. Yeah, you're not. I told you to put bullet points and explain. It's like you're just reading those, and we can easily, if you can forward us this same paper, everyone will read the same thing. Don't repeat it. I'm telling this
Yes,
to everyone. Even Nikita also, she showed a presentation. It's like copy paste of the textbook or whatever is there in that paper. You people have copy pasted and start reading. That is not how you do a presentation. You should put up few points, as Shanai sir also pointed out. You could have just said signs of sigmoid volvulus, one U or C-shaped appearance, coffee bean appearance, and then you could have explained everything rather than putting that entire sentence there.
okay, sir. I'll
Go
change
on.
it, sir. In the sigmoid volvulus, the twist will be towards the left quadrant, and in the cecal volvulus, it will be towards the right lower quadrant. This radiograph shows cecal volvulus, C loop pointing towards the right lower quadrant. Radiographically, diagnostic signs includes when there is dilated small bowel greater than 2.5 to 3 centimeter, and there is paucity of colorectal gas, the stretch sign, gasless abdomen, dilated stomach, and in upright position when there is multiple air fluid levels or air fluid level wider than 2.5 centimeter, and air fluid levels in the same bowel loop of unequal heights and string of pits and as explained. And in large bowel obstruction, when there is colon dilated greater than 6 centimeter or cecum dilated greater than 9 centimeter and paucity of rectal gas. Coming to CT, it is accuracy for diagnosis both small bowel obstruction and large bowel obstruction with greater than 95% of specificity. And major diagnostic finding will be in the CT is proximal dilatation with the distal compression of bowels. In the CT, when there is intestinal dilation of greater than 2.5 centimeter of small bowel, colon greater than 6 centimeter and cecal diameter greater than 9 centimeter, it is considered as dilated bowels with obstruction. And the cross-sectional of the CT allows to find the transition zone. The transition zone is where the dilated proximal bowel transitions to non-dilated distal bowel.
What are the advantages of CT, man? Praveen, what are the advantages of CT?
Compared to X-ray, what will you get additional information in CT?
Sir, we can get the vasculature, sir, of the bowel.
Vasculature, how, man?
Vasculature, how you have to give if you're suspecting ischemia, okay, you give IV contrast and all that, then it is fine. More than that, what is the main difference? If there is a suspected obstruction, what additional information you will get in CT?
Nikita?
Think,
Look,
Nikita. I think Enas is also there.
Site and
Enas?
cause.
Yes, Vinod.
Vinod, tell us. Vinod, tell man.
Site of obstruction and
What?
site of obstruction, sir.
Okay,
And cause of obstruction most of the time.
correct. Cause of
Cause means what? Whether it is?
Malignancy or some
No, not malignancy, man. Common, mechanical, or it is
dynamic or
adenine.
adenine.
Whether it,
paralytic list.
and also whether they sometimes they can tell if there is adhesions also, anterior abdominal wall cross adhesions. So that is how you differentiate, and you can change alter your plan of management, and also it can show wall thickening, suspicion of ischemia, ongoing ischemia, or strangulation.
What if you see something, you will almost virtually immediately operate. What is that sign, man? Vinod?
Sir?
If you see something
What
in
is
the bowel wall, you will have to immediately consider surgery. What is that sign?
Praveen is pointing to something there. I don't know whether it is there in this
Air bubble in the bowel wall, sir.
Ah,
wall. Correct. What is it called as?
Sir, it can be like
Diaphragm.
field of perforation.
Pneumatosis intestinalis.
Yeah. Pneumatosis intestinalis. What is it, Vinod?
Field of perforation also can sometimes show the air in the bowel wall.
Don't go thinking about rarer things, man. What is the commonest thing? Wall. If you're suspecting intestinal obstruction, and if you're see air in the wall of the intestines, invariably that is a pathognomonic sign of ischemia,
leukemia.
Yes, sir.
rather than shield of perforation. Nobody will think it as shield of perforation. In shield of perforation, you will see air adjacent to that area, but there will not be contrast extravasation. Like in appendicular perforation, shield of perforation, you will see pockets of air surrounding in the collection there. And
Yes, sir.
probably there will not
Outside
be
the
any
bowel
contrast
wall.
extravasation. Outside the bowel wall, if there is pocket of air around the collection, and if the contrast is not extravasating beyond the bowel, then you suspect that it's a shield of perforation. Not when you see air in the wall of the lumen, the bowel.
Yes, sir.
So
Go on.
CT will characterize
Yes, sir.
the site of obstruction, possibly the cause of obstruction, and also the effects of obstruction. So it will give you lot of information.
And also it can be sometimes therapeutic if it is due to
Subacute.
adhesions,
Yes.
subacute or partial obstruction.
Yes, sir.
Okay, next slide.
Small intestinal ileocecal interception can be visualized as target sign in axial and sausage sign in coronal views. First picture shows
Praveen, have you
target
put
sign.
it? Have you put that thing ulta, or is it correct?
Sir?
You're saying
sir.
ileocecal
This is-
interception,
Yes, sir.
and it is on the left side, whatever you are showing.
Picture is different.
This is colonic
It is
intersection.
You're talking about, you're saying ileocecal and you put something else there.
That's not ileocecal, man. It is correct only because liver is on the right side.
interception. Yes, sir. Yes.
No, the first picture I'm talking about.
It is colonic interception, sir.
Yeah. But your title is you're talking about as ileocecal interception, and you have put up the picture of colonic interception.
Interceptions can be visualized targets and sausage signs.
That is what we know, man. When you're
yes, sir.
talking about why, then you should have put it up as the same, just pictures.
Yes, sir.
Colonic interception. You said ileocecal interception, and then you are explaining the picture of
Yes, sir.
colonic interception.
Yes, sir. Colonic interception, sir. Mistake,
Yeah.
sir.
So this is where you should use your common sense there,
Yes, sir.
rather than just blindly copy pasting. Go on.
In colonic volvulus, you can see a wall sign that is The segment of redundant colon is elongated and dilated, associated with twisting of mesocolon. SS. And radiographic signs suggesting of bowel ischemia is when there is wall hypoenhancement or heterogeneous enhancement with IV contrast, or when there is hyperattenuation without IV contrast, when there is wall thickening greater than 3 mm, mesenteric edema, engorged or occluded mesenteric vessels, pneumostasis intestinalis, portal venous or mesenteric venous gas, free intraperitoneal fluid, and wall sign.
So all of it, whatever we asked, are already there here. You are not able to
Yes, sir.
answer. Go on, go on.
Yes, sir. This will be the short flow chart for the management.
No,
which
but
will
you
be-
said management sir will be
Yes, sir.
talking. No,
Yes,
why
sir.
you're
Yes,
talking
sir.
about
Sir
it
will
then?
be talking, sir.
Yeah,
Okay, I think it's already time anyway.
already 10 time.
Yes, sir.
Sania,
So I think
Yes, sir.
what is your view of how we presented today?
I just copy pasted and kept reading, sir.
Hmm.
Not a like he would have explained it and discussed with us. I felt.
I think Niranjan, can I?
yes, sir. Yes, sir. Yes, sir. For comment, sir.
Praveen, I think you had started presenting well. Again, you have gone back. Don't take these things. See, we are not idiots coming to sit in this class. See, all of these information is available. I think we already knew it. And if we needed to, we can just consult either any textbook. We will get all this information. So your job to while presenting an intestinal obstruction is to highlight the salient features in terms of what are the common things in these particular age group and how do you differentiate between this one. I think all the information was there, but you just kept on reading it rather than understanding and explaining it. So you have to get back to preparing properly, put bullet points and just explain things rather than just copy paste from a textbook and then just keep reading it. That is, it's useless both for you and us, because you will tomorrow if I ask you, you will have forgotten everything. So it is not useful. You have to analyze in such a way that it is like your brain. You have to compartmentalize the information. So the moment you want to recall, if you open a particular file, you will be able to recall all the necessary information you need. So that is how you need to understand and store it in files, different files, just like the brain does or computer does. Okay. So this is actually meant for you to understand. It's not a criticism, but if you keep presenting like this, we will not need to have any classes. It's waste of your and our time. Okay.
Yes, sir.
And
So,
also,
yes,
you
sir.
get caught out whenever you're using references. Try to use the recent ones. And that too, for such a common topic of intestinal obstruction, you're using a reference of 2011. So you got caught out with respect to terminologies also there. Carcinoid tumor, for example. So you need to think and see what you're putting it up. And also, whenever you are using references, good you use references as this thing and not from copied pasted from a textbook, but use the newer recent ones rather than use the ones which are almost like 2011. For a topic like intestinal obstruction, not much has changed, but certain things would have changed.
Yes, sir.
I think if there are no questions or comments, sir, we will end the class, sir.
Yeah. Thank you.
Yeah.
Thank you.
Thank you. Thank you.